Dear colleagues, welcome to our dialogue. This is a special dialogue because we are between Christmas and the New Year, so it's a special flavor. This dialogue, the main purposes of this dialogue are two. First, to celebrate the new year, which is coming, which is starting soon. I know it is a very difficult time, but by nature, I'm optimistic, and I hope that our leaders will find the meeting point based on the notion that what human beings have in common is much more important of what human beings do not have in common. So let's be optimistic for the future. And the second goal today, the main goal, is to celebrate the year of the last year of the European Art Journal. It's been a very successful year. We published 48 interesting issues. Our impact factor is more than 38, and our papers have been downloaded more than 11 million times, which I think is a remarkable number. A successful year thanks to the contribution of our editors, our reviewers, our authors, and of course, our readers. The intention today is to celebrate this very successful year, summarizing for you some of the most important papers we published in the last 12 months. And this mission will be accomplished with four remarkable editors of the European Art Journal. Lale Tokgozoglu from Ankara, deputy editor for dyslipidemias. Margarita Brida, originally from Croatia, now in London, for congenital heart disease. Cecilia Linde, executive editor for heart failure and president-elect of the European Society of Cardiology, and Susanna Price, deputy editor for acute cardiovascular care and vice president of the European Society of Cardiology. I'm really grateful to these four remarkable ladies because of for their contribution to the success of the European Heart Journal. With their intelligence, wisdom, and dedication, their contribution to the success of the journal has been really remarkable, and really happy to share this last dialogue of 2024 with them. And what we will do today will be to ask each of them to summarize the 3-4 papers, important papers published in their main field of interest. And then we'll open a short discussion, questions and answers. Of course, our goal is to involve you in this discussion, in these questions and answers. We will cover these 4 topics. Let's start with prevention. Let's start with dyslipidemias in particular. As I told you, Lale is the deputy editor for dyslipidemias, an exciting field with incredible developments in the last few years. And Lale will mainly focus on the important papers we published in 2024 in this important field of cardiovascular medicine. Lale, please.
Thank you very much, Filippo. Merry Christmas and Happy New Year to all. So this has been a really exciting year in the field of lipids, providing us new insight on biomarkers and lipid-lowering therapies. It was very difficult to choose from some excellent papers. What I will do is just focus on 3 concepts. Now, earlier and lower LDL is better is the norm today. But a paper published in the European Heart Journal supports a new concept, which is faster is better. This has also been suggested by some imaging trials. So the authors investigated the relationship between non-HDL cholesterol levels after myocardial infarction and risk of adverse outcomes. They evaluated 56,000 patients with myocardial infarction from the Sweetheart Registry with a follow-up of about 5 years. Non-HDL cholesterol was chosen as a simple aggregate measure of atherogenic lipids, and they measured it at admission 2 months and 1 year. Non-HDL target achievement of less than 2.2 millimole per liter and cardiovascular outcomes of MACE, death, and non-fatal MI were assessed. They found that patients who achieved an early and sustained non-HDL goal had the lowest risk of all outcomes. And the larger the decrease in non-HDL, the greater the absolute and relative benefits on endpoints. Their findings were consistent across age, sex, and comorbidities. They also performed a secondary analysis and showed that patients with the greatest reduction in non-HDL at 2 months, which was the earliest they measured, had the lowest rates for outcomes. They also showed that patients who use high-intensity statins or combination from the beginning also were more likely to achieve non-HDL goals. Of course, the study was observational in nature, so this is a limitation. And the data was collected from the follow-up visits and adherence obviously not known. But still, I think that this paper is important because these findings challenge the current stepwise approach for cholesterol lowering after myocardial infarction and confirm that getting to goal faster is better. Of course, safety, feasibility, and cost effectiveness needs to be studied, but I think this interesting new concept is opening us new pathways for exploration. And the new ACS guidelines, I think, are a step forward, recommending more intensive therapy from the very beginning. The second paper, the second topic I want to go into has to do with biomarkers because we're increasingly understanding the importance of the risk caused by Lp(a) and high-sensitivity CRP in atherosclerotic vascular disease. Now, we also know that a recent trial that showed that high-sensitivity CRP, LDL cholesterol, and Lp(a) levels at baseline predicted incident cardiovascular events in women during a 30-year follow-up, with each biomarker independently contributing to overall risk. So in the paper I want to discuss, the authors investigated whether systemic low-grade inflammation modulates the association between Lp(a) and coronary heart disease risk. It's a publication from the Biomarker for Cardiovascular Risk Assessment Across Europe Biomarker Project. The authors used data from 71,000 participants from 8 prospective European cohorts. Of these, about 66,000 participants had not had an event before and did not have established coronary heart disease, and the remaining 6,000 or so had established coronary heart disease, and the follow-up was 10 and 14 years respectively. An incident coronary heart disease event occurred in 5% of the patients free of heart disease initially, and 22% of the patients in the secondary prevention group. They found that Lp(a) was significantly associated with incident coronary heart disease, regardless of high-sensitivity CRP, in the cohort without previous coronary heart disease. But interestingly, Lp(a) was related to recurrent events only in those with high-sensitivity CRP above 2 milligrams per liter in patients with coronary heart disease at baseline. This study had the limitations of being just a European cohort. The use of lipid-lowering therapies was slightly lower than standard of care, And the measurement of Lp(a) was in milligrams. We usually tend to believe that millimole is a better way of measurement. But this paper, I think, shows the interplay between Lp(a) and inflammation is more complex than what we think. It may change over a lifetime with the accumulation of risk factors and the presence of atherosclerotic vascular disease. And we still need to learn a lot more from the interaction of these risk factors. But I think these findings might guide adequate selection of high-risk patients for the forthcoming Lp(a) targeting compounds that we are expecting to come out next year and then further on. And the third paper, moving on, brings some hopes to patients with homozygous familial hypercholesterolemia. So this is the reason I selected this paper. We know that these patients get limited benefit from conventional lipid-lowering therapies. And evinacumab is a monoclonal antibody targeting angiopoietin-like 3, works in the absence of LDL receptors, and it's approved for the treatment of patients with homozygous familial hypercholesterolemia. The paper I want to discuss is the largest and longest follow-up safety and efficacy paper on evinacumab in patients with homozygous familial hypercholesterolemia. This is an open-label phase 3 trial from 12 countries. They assess patients above the age of 12, mostly adults, but they also had some adolescents, and half of the patients were female. These patients received monthly injections of 15 milligrams per kilogram evinacumab and were treated for a median duration of about 100 weeks, up to 4 years. The mean LDL reduction was 44%. It was more in those with higher levels in the beginning. So the reduction was higher in females and younger patients, going up to 55% reductions in some. Evinacumab also significantly decreased ApoB, non-HDL, triglycerides, and interestingly, Lp(a), although it was a decrease of about 10%. There were no major safety signals, and the most common adverse events were nasopharyngitis, headache, and flu-like symptoms. Overall, evinacumab was well tolerated, confirming the efficacy and safety over long term. So these are just 3 of the very good papers that we received this year. All 3, I think, are bringing forward new concepts that will open the path forward. And we look forward to what's coming up next in our field.
Lale, thank you very much. 3 very interesting papers you have summarized for us. Very, very stimulating. And now I would like to open the discussion, short questions and answers on these 3 important papers on dyslipidemias in general. I remind you that we are live streamed in X, and this dialogue will be then posted in X and YouTube. So for those who cannot join our dialogue today, they will find it in X and YouTube. But now questions for Lale. Any question? Waiting for question from the audience, and I encourage you to write your question in the chat, and our speakers will be happy to address your questions. Lale, I start with a question which might be the title of a congress. Coming to the residual lipidic risk beyond LDL. What comes next? I see 2 main challenges. One is Lp(a), and we are learning that this is important in explaining residual lipidic risk beyond LDL cholesterol. Another target might be remnant cholesterol. What are your views in this regard?
I think the most important risk factor is getting LDL cholesterol as low as we can, because that is where we have most of the evidence. And most of the risk we thought to be residual is actually from not lowering LDL cholesterol enough in some patients. In addition to that, we're learning more and more about Lp(a), which is much more atherogenic than LDL cholesterol and is becoming a target in itself. And hopefully, we'll be able to have therapies that modulate cardiovascular risk through Lp(a) reduction, but this needs to be confirmed yet. And inflammation is overwhelmingly important, but whether we're going to be able to lower it without altering our defense systems is another issue. But new therapies targeting the NLRP3 inflammasome, specifically interleukin-6, are showing a lot of promise. So I think these three will be extremely important. As for remnants, we do know that they are atherogenic, but we still need good therapies to lower them. And the triglyceride-rich lipoprotein lowering therapies that are targeting ApoC3 and ANGPTL3 are still in their very early phases. But I think there's hope there as well. So I think abolishing all the ApoB containing lipoproteins and controlling inflammation will be important, but prioritizing will be difficult, and which to address in which patient will also be an issue. So I think we need to learn a lot more than we know today to go forward.
Thank you for being so clear and impactful, Lale. I see a question from Jan Piek. Jan, please, let's unmute Jan, and you're very welcome, please.
Okay, thank you very much for the interesting contribution. You mentioned about the sweetheart, about results post-MI. But do you know, or can you speculate what happens to patients with stable angina?
Imaging studies are suggesting that in acute coronary syndrome patients, we are more likely to get benefit from faster reductions. So I would assume that the priority for a fast reduction will be post-ACS patients. But it may work for chronic patients as well, but the impact will probably be less, is what I think. Plus, those patients are not at imminent risk as much as those in which we're expecting a recurrent event.
Okay, thank you very much.
Thank you.
Thank you. And before moving to the next speaker, I see in the audience Peter Libby, who is a top expert in many things and also in lipids. Peter, any question or comment from your side?
Yes, well, hearing Lale's answer to the remnant and triglyceride-rich lipoprotein questions, like hearing myself talk, so I have nothing to add. I think that the move in Europe to begin ezetimibe with statins, certainly in secondary prevention, is the way to go. I think the U.S. practice and U.S. guidelines are behind. So I see no reason not to dispense ezetimibe with starting statins at the same time. Ezetimibe is now generic. It's inexpensive, should be inexpensive, and is pretty much without any side effects or drug-drug interactions. So I really endorse the European position and will use whatever influence I have, which is slim in this continent, to push for a change in practice and guidelines here.
Thank you very much, Peter. Lale, thank you very much. And now we move to the next speaker. It's a different topic. Next speaker is Margarita Brida. The topic is adult congenital heart disease. And this is an extremely important field of cardiovascular medicine of growing interest, also because for the first time, the number of adults with congenital heart disease is larger than the number of children with congenital heart disease. And this is evidence of the success of this field of cardiovascular medicine in the last few decades. So an exciting field for an expanding number of patients. Margarita, what are your articles?
Thank you very much, Filippo. First of all, happy holidays to everyone. It is truly, truly wonderful to be here on this forum, and absolute pleasure to be with these grand ladies that I have a privilege to be. So thank you so much, Filippo, for your kind invitation. very special Christmas edition. So I was thinking about 3 papers to choose from the field of congenital heart disease, and obviously it was not easy, as Lale pointed out, for her field as well. But I decided for 3 European Heart Journal contributions that I am hopeful will have impact on the clinical practice. And, truly, as you mentioned, because we are dealing with rapidly growing, but not only rapidly growing, but I would also say aging population of adults with congenital heart disease. And to continue on the Lale prevention, the first paper that I chose is entitled Acquired Cardiovascular Disease in Adults with Congenital Heart Disease. And it is a call to action for timely preventive measures. It was a clinical consensus statement that contributed European Society of Cardiology Working Group on Congenital Heart Disease in collaboration with European Association of Preventive Cardiology and also European Association of Percutaneous Cardiovascular Interventions. And I think, as you nicely pointed out, and thank you so much for your always support for this field, which really needs this, I would say, almost desperately. We are treating congenital heart disease today very well from the congenital point of view, I would say. However, we almost, and I would dare to use the word forget, that these patients can also have and do have increased risk of premature atherosclerotic cardiovascular disease. And this is for multiple reasons. And in these patients, we have increased morbidity and increased mortality following cardiovascular event in comparison with the general population of similar age. And what is very interesting to point out that 2021 ESC cardiovascular prevention guidelines, they do not address this specific population. So in this consensus clinical paper, the authors suggest appropriate screening strategies and also therapeutic goals, especially for this very specific patients with adult congenital heart disease. So I would definitely invite general cardiologists and cardiologists who are very much involved in congenital heart disease to also read this paper on acquired cardiovascular disease in this population. So that was my first paper that I chosen. The second paper is entitled Three-Dimensional Cardiac Magnetic Resonance Allows the Identification of Slow Conductive Anatomical Isthmuses in Tetralogy of Fallot patients. So very fancy title, but I will try to explain it in a very simple terms. As we all know, Tetralogy of Fallot is the most common cyanotic heart defect, and today operative repair is highly successful, and we do expect long-term survival of patients born with Tetralogy of Fallot. We also know that the most frequent long-term issues that we see in our adult patients is pulmonary valve regurgitation. It is consequence right ventricle remodeling and also ventricular arrhythmias. So today there is increasing interest in performing EP study to assess for potential latent ventricular arrhythmia substrate. This is before we put the pulmonary valve in place, because we know that putting pulmonary valve percutaneously or surgically can preclude access to the myocardium of the RVOT that is necessary for us if we want to do catheter ablation. So we tend to do this before we put the valve in place. So this specific paper that was published this year in European Heart Journal proposes non-invasive identification of slow conductive anatomical isthmus in Tetralogy of Fallot patient. So in simple terms, to say that we can now, with 3D CMR, identify abnormal myocardium that is responsible for the majority of ventricular arrhythmias in Tetralogy of Fallot. And in this paper, they have accomplished this with 3D CMR, and they have made a direct comparison with electroanatomical mapping data. And also on top of that, the authors provided validation cohort of patients to validate their work. And in fact, they show that identification of normal versus this slow conductive anatomical isthmus that is responsible for ventricular arrhythmia can be achieved with 3D CMR with high sensitivity and specificity. So I thought that was really a groundbreaking achievement from the group of Netherlands and group of France that was led by Dr. Kimura and Dr. Katja Zeppenfeld, because in the future, obviously with training, with appropriate equipment, that obviously all takes time, but we could reduce the need for diagnostic EP studies in these patients. And also, as we know that with age, as we all grow older, these patients can develop this slow isthmus, which may not have been present 10 years ago. So that would mean that we would need to repeat the EP study every couple of years or every decade, but still a lot. And if we could potentially do this with 3D CMR, obviously that would be much more beneficial for our patients and also for us. So that was the second study. And the third is not an original study, which I wanted to finish with, which is actually the state-of-the-art review. And you will forgive me, but I decided to choose this rather than the original paper, to really still feel that we need to raise awareness of this, as you nicely pointing out, rapidly growing population. And again, I would add aging population because of really, really good pediatric contribution and also adult cardiology contribution. So the third paper is entitled Adult Congenital Heart Disease, What Every Cardiologist Should Know About Their Care. And this is written was written by Professor Werner Boots. I see here on the call my dear colleague and friend, Professor Katja Prokshelj, and I also see on the call Professor Michael Gazoulis, who were all contributors to this paper. So I'm very pleased for that as well. And we have really provided 7 guiding principles, most importantly saying, you need to know the medical and surgical history of each patient in detail, because this is the only way that you can follow it closely, that you can understand what can be potential issues, and you really need to know the basic outcomes of specific, especially very common congenital heart disease. And education here is crucial, education of patients, but also education of ourselves as cardiologists. And obviously, last but not least, whenever in any difficulties, we should ask for tertiary center for expert advice for congenital heart disease. So this was very short, I hope, from my side, which will hopefully leave us some room for questions. Thank you.
Thank you, Margarita. Again, very clear and very impactful. And I think we can be really proud of these important papers in your field of interest that we published in the European Heart Journal. Again, this presentation is open for questions. As usual, we have a very global audience from the 5 continents. Recently, I've been informed that our papers are downloaded, some of our papers are downloaded even in the Antarctic, which I think is another remarkable observation. So the European Heart Journal is really everywhere. Questions for Margarita? Brilliant presentation, 3 important papers. If I don't see questions at the moment, Margarita, I ask you a question. I think if I will remember, yes, definitely something we have published. In patients with congenital heart disease, an important challenge is also cardiovascular disease beyond the congenital heart disease, because in these patients, we tend to focus on the complex congenital heart disease, but life expectancy is much better than before, thanks to your efforts. And these patients also tend to develop other cardiovascular disease, which perhaps are overlooked because we focus on the main disease. Any comments on this issue, which is of general clinical interest?
Yeah, I think this is now really, really important topic, because we made really contribution, I think, in the last decades and more in terms of treating the very congenital issues. And now we have a consequence of that, right? Now we have this growing population of older people who are living with congenital heart disease, but they are doing good. And we need to take it now a step further to educate these patients about healthy lifestyle, about preventive measures, everything that goes so firmly and is discussed so firmly for general population, I think needs to be highlighted even more in congenital heart disease, because we do know that if you have a substrate already, and on top of that, for example, you get a myocardial infarction, of course, your outcome is going to be worse than if you have been completely healthy before that. And I'm really happy that Professor Gatzoulis is with us here, because, you know, he is in congenital heart disease, one of the prime people who is always highlighting importance of these preventive measures and educating patients of a healthy lifestyle and very simple general preventive measures. But also we know from some studies that in comparison with general population, for example, very interesting, congenital patients do not get lipid lowering therapy, for example, going to the LALA before, as often when indicated per guidelines as, for example, general population. Probably here is a complex situation where there is still influence from pediatric, where these patients are in general younger than the ones with the general population who develop hypercholesterolemia, for example. And then there is a little bit of, I would say, difficulties between cardiologists to start the medication and also from the patient to accept to take the medication, while in fact they need it much more than general population. Just put as example patients with coarctation of the aorta, which even after the repair, we know they can have arterial hypertension that persists, and they can have really in early stages, in their 40s already, atherosclerotic disease developing. And here it's really, really important prevention.
Thank you, Margarita. Very important topics. Well, the Netherlands are very active today. Jan, please, can you ask your question?
Yeah, thank you very much. You mentioned a little bit about in congenital heart disease, the premature development of cardiovascular disease. So my question to you is, how should you monitor these patients? Would you advise to have a CT scan from your coronaries at a certain age, when they become 40 years old or whatever?
Yeah, that is a very good question. Well, I guess, you know, there is multifactorial reasons why these patients could develop premature cardiovascular disease. And one of the reasons is inflammation due to repeated, sometimes operations, interventions. It can be anatomically different coronary arteries. In transposition of the great arteries after arterial switch repair, you need to reposition coronary arteries, so it can be kinking. All this can, any LVOT obstructions that they often have, like I mentioned, coarctation of the aorta, hypertrophy of the ventricle, dilatation, all this can contribute to early development of coronary artery disease. So in fact, for those that we know are at very high risk, for example, I mentioned transposition of the great arteries with arterial switch, we do CT, because also we know that they don't have chest pains typical because of the previous operations. In other ones that are not at high risk, so this is why it's also important to understand which patients with congenital are at higher risk, which ones are, let's say, in the similar risk as the general population. I like personally, whenever I have a patient transitioning from pediatric to the adult, to once do just a lipidogram, just to make sure that there is no some underlying hypercholesterolemia. We also have syndromic patients, the Down patients, the patients with Turner syndrome and so on, that we know have higher risk factors as well. So I like to do this baseline, and if everything is fine and they're having a healthy lifestyle, they're not overweight and obese, then I obviously do not repeat this very often, but I screen them initially, let's put it that way.
Okay, thank you.
Thank you, Margarita. Thank you again for your presentation. Now we move to the next speaker, but for those who have questions for Margarita, you can write it in the chat, and Margarita will give the answer in the chat. Now we move to the next speaker from the expanding universe of patients with congenital heart disease to the pandemic of heart failure. And Cecilia Linde will summarize for us the important papers published in the journal in the field of heart failure. Not an easy selection because we published a lot in this regard. Please, Cecilia.
Thank you very much, Filippo, and hello, everyone. Happy holidays. I see a lot of my friends, and I'm very happy to see so many from China. It's a long, big time difference, so especially happy to see so many of you. Well, over the last decade or more, we've seen an amazing development of heart failure medication, in particular for heart failure with reduced ejection fraction, and in later years also for HFpEF. So what about the mortality? Well, interestingly, in the United States, there was a breach in the decline of heart failure mortality after 2012, and instead a small increment, which is alarming. So in Sweden, we looked at the same thing, Lindberg and co-workers, in a 25-year-old study on trends in heart failure mortality between 1997 and 2022. And indeed, there can be seen a decline in heart failure mortality, and not like in the United States with a breach, but continuous decline of, on the average, 2.12% yearly. But using the National Patient Registry source, we can still see that there is a high mortality, 1-year mortality after incident heart failure, 25%, 3-year mortality, 46%, and 5-year mortality, 58%. So this, of course, is a mixture of different heart failure types, but it just says there's a lot that remains to be done. Looking into heart failure types, the decline in heart failure mortality was less in HFpEF than in HFrEF, and also less in the elderly. And women in this study had mortality rate than men. So what this study says, that there must be some difference between the United States, at least compared to Sweden, whether it's how heart failure patients are registered, or whether the access to modern medication is not the same in the United States and in Sweden. But most importantly, from the study itself, it shows the need for more medications in heart failure with preserved ejection fraction. And there has indeed been some improvements there with the SGLT2 inhibitors and with MRAs, as demonstrated in the Fine Arts study, which compared finerenone to placebo in HFpEF patients and showed a reduction in heart failure events and cardiovascular death. So that brings me to my first choice, which is also the most cited and most downloaded of the heart failure-related papers this year, and that's titled Semaglutide and Diuretic Use in Obesity-Related Heart Failure with Preserved Ejection Fraction, a pooled analysis of STEP-HFpEF and STEP-HFpEF diabetes trials. And in the initial trial in obese heart failure patients, semaglutide was associated with improved exercise tolerance, quality of life, improvement of inflammatory parameters, which is very promising here. What the authors wanted to do in this pre-specified analysis, pooling these trials together, was to see whether diuretic use in some way affected the results of semaglutide. And in short, it did not. But let's just look at these patients first. There were some 1,146 patients. Of these, about 1/5 were not on any diuretics at all, 1/5 on non-loop diuretics, and the 60% were on some degree of loop diuretics. And there was a weight drop in irrespective of diuretic use or not. There was also an improvement in quality of life, but much greater effect in those who were on diuretics, which could mean that there is some other effect on semaglutide, not just weight loss. Moreover, what was very important was that in those on diuretics, there could be a reduction of diuretic dose, about 11.8 milligrams, and there was less institution of diuretic therapy in the semaglutide group compared to those who were assigned to placebo. So this says that for a long time, diuretics was the only available therapy in HFpEF. But in these obese patients, this is an asset which this is not an outcome study, and that's very important to add, but it does says that not only are symptoms improved and the weight is lost about 11%, but also the need for diuretics may be reduced. And that is important because that, of course, is connected to renal function. So that needs to be further studied in outcome studies, but it's really promising results. Finally, I would like to go into a totally different topic, and that is, when should an ICD be given? How long should you wait after you start heart failure medication? And that, of course, very difficult question to answer. But the heart failure opt investigators by Christian Feldman and co-workers tried. And they did a study on 600 patients, both in the United States and in Europe. And those were hospitalized patients who had what was called an indication for a wearable ICD. So they looked at what happened with the ejection fraction over 90 days, 90 to 180 days, and throughout a year. And our guidelines say that we should wait about 3 months with optimum medical therapy. And if a patient still has ejection fraction below 35%, that's when a primary preventive ICD is indicated. But this study shows that you maybe should wait longer, because there was an improvement of ejection fraction from initially on the average 24% in these hospitalized patients from the beginning to 46% had improved to ejection fraction be above the indication for an ICD, above 35% after 90 days, and 66% after 180 days. And at 1 year, 77%. So that says that all the improvement doesn't happen in those 3 months, or the guidelines tell us to wait. And of course, improvement of ejection fraction was related to heart failure etiology. In this cohort, about 70% had dilated cardiomyopathy, non-ischemic cardiomyopathy, and that was a predictive of a greater improvement in ejection fraction, as was atrial fibrillation, presumably because heart rate was normalized during that treatment period. So it just says that irrespective of our trials to optimize medical therapy, I'm sure these investigators did, somehow they didn't reach target dose within 90 days. And even if they did, there was still incremental effect over 1 year. This, for me as a device doctor, does not come as a surprise because in the cardiac resynchronization therapy studies, which is not new onset heart failure, but is chronic heart failure, we have been able to observe continuous improvement in ejection fraction over 1.5 years. But it doesn't help the clinician very much, because at some point you have to decide on when to give an implantable cardioverter defibrillator. So the take-home message is to do up titration as quickly and as efficiently as possible, and at least try to wait maybe 6 months if a patient doesn't have any disturbing signs of sustained ventricular tachyarrhythmias. So this is not a crystal clear reply. I'm aware of that, but it just says that in spite of all our efforts, we can do better in optimization of heart failure medication and perhaps avoid unnecessary ICD. So good hope for HFpEF with the MRAs, SGLT2 inhibitors, and potentially in obese patients, also GLP receptor agonists. And we need this perhaps can reach the mortality in HFpEF, which we still need to fight, especially in relation to HFrEF. But I think that the overall take-home message is still residual, rather substantial mortality in heart failure, irrespective of ejection fraction, and still room for new innovations. Thank you.
Thank you, Cecilia. 3 stimulating, interesting papers, so well presented, and I think that unfortunately we don't have a long time for discussion, but I'm sure that your papers will stimulate questions in the audience. Again, waiting for questions, I ask the first question. You've been one of the founders of cardiac resynchronization therapy. Your contribution to the history of cardiovascular medicine in this regard is memorable. And I'd like to ask you something in this field, related field. What about ablation and pacing in patients with heart failure? I think that this is an interesting topic, perhaps still underutilized, although now we have some papers also published, some studies published in the European Heart Journal. What are your feelings about is ablation and pacing in patients with AF and heart failure something which will enter the clinical arena?
Well, if in the general heart failure patients with atrial fibrillation, early atrial fibrillation ablation is probably related to better outcome. Being aware of the fact that the studies that have been conducted have not been very large, but have shown substantial improvements. Waiting longer to do the ablation will reduce the potential of reverting the patient into sinus rhythm and keeping and staying in sinus rhythm. So I think that many cardiologists are reluctant to refer patients for atrial fibrillation ablation and shouldn't be. For those beyond that, say with chronic atrial fibrillation, but still with a irregular heart rhythm problem and a rapid heart rhythm, his ablation and combined with cardiac resynchronization therapy is an alternative, especially in elderly patients.
Along the same line, the second question, what about his bundle pacing? We don't have trials yet, I would say surprisingly, but physiologically seems to be a stimulating approach, including patients in patients with heart failure. What do you see in your crystal ball in the future?
Well, I think left bundle area pacing, which is somewhat easier in the sense that you get a better pacing threshold, which stays over time. That has the most promise. That has a learning curve that seems to be associated with better improvement in ejection fraction and less events than traditional cardiac resynchronization therapy. But we do need the trials to be able to actually say that, and lots of those trials are ongoing.
Very well. Thank you, Cecilia, for this very interesting dialogue on heart failure. And now we move to the last speaker for today, Susanna Price. The topic is acute cardiovascular care and ischemic heart disease. Susanna, thank you again for your wonderful contribution to the journal, for the exceptional things you are doing in the journal and also in the European Society of Cardiology. We are really eager to listen to your papers.
So thanks, Filippo, and I'd say happy holidays to everybody around this very special time of year. And it's really a great opportunity, I think, to look backwards, but also maybe look forwards a little bit. And as Filippo said, I'm focusing really on the acute side of things. And for 2024, I've chosen 3 papers for you from the European Heart Journal. One relates to acute myocarditis, which I think was a very important paper published earlier this year. And then moving towards the end of the year, so to October this year, looking at cardiogenic shock, because really that's the only area that people are really focusing on with respect to critical care at the moment. And there are reasons for that. And I think one of the things that the European Heart Journal has done is fostered a very balanced and mature debate at positioning where we are with these very sick patients and where we might go in the future. So my first paper was the first authors, Professor Caforio, published in July this year, and it's looking at endomyocardial biopsy in acute myocarditis. And it's looking at prognostic utility in pediatric and adult patients, and it's from EORP, looking at cardiomyopathy and myocarditis long-term registry. Now, the reason I've chosen this is that there isn't much high quality data in this area. And when you're faced with a patient where you're trying to make decisions as to how to manage them, you need the best data you can to help you make those decisions. And this is an important paper. What they aimed to do was to look at the baseline features of these adult and pediatric patients with acute myocarditis, look at what happened with a 1-year follow-up, and look at predictors of outcomes. And they used the ESC 2013 criteria when they were defining acute myocarditis. They looked at 46 different centers across 18 different countries in Europe. They had just over 580 patients, of which 88 were children. So that's a median age of 8 years for the children group. The remaining 493 were adults, and these were young. Their median age is only 38 years. And they divided them into 3 groups, these 581 patients. Group 1, clinically suspected with an abnormal CMR. Group 2, biopsy proven. That was 222 patients, so around about 35-40% of the patients. And group 3, clinically suspected with a normal or inconclusive or no CMR. And they looked at baseline features, and then they looked at 1-year outcomes. And this is rehospitalization, cardiac, whether they had transplantation, whether they had a VAD, and whether they had an ICD. So what did they find in their results? Well, they found that of those 222 patients who'd had an endomyocardial biopsy, the complication rate was very low. There were no deaths, either in adults or children, related to the endomyocardial biopsy, which people are frequently reluctant to undertake, but there were procedural complications. I think, importantly, of those biopsied patients, 1/3 of the children and 2/3 of the adults only had classical myocarditis. So looking at the utility, this is biopsy proven acute myocarditis, it has to be thought about in a critical way. So your negative CMR may not tell you that the patient doesn't have myocarditis. At the 1-year follow-up, the results in terms of the outcomes for the patients were actually not bad. So 2.7% of patients died, 1.7% received a transplant, and 0.7% underwent a VAD. So easy to remember. And the predictors of the worst outcome were a worse ejection fraction and also the use of immunotherapy early on. And I think for me, this is an interesting paper because it gives us some kind of contemporary idea of what's going on in Europe. It gives us reassurances in terms of pursuing the diagnostics that you have in these patients. And these are potentially very sick patients. About 50% of them had heart failure or shock, and 1/3 of them had major arrhythmias. I think also of interest was in the biopsied patients, more than 80% of them had lymphocytic myocarditis. And then moving towards sort of the end of it, what matters here is looking at the level of certainty approach. So the combination of clinical, biopsy and also biomarker features that make you think the patient may have acute myocarditis, thinking about risk stratification of these patients, and of course treating them, because the treatment rates were very low, even if a patient had had an endomyocardial biopsy. So that's my sort of first paper, and it really is one that makes you think about your own practice. And then moving to the second and third of my papers, they're really intertwined, Filippo, and they relate to devices and in cardiogenic shock. So if you cast your memories back to 2023 at the ESC, Holger Thiele presented ECLS shock. And now in October this year, we've now got a 1-year follow-up from those patients published in the European Heart Journal. The first author for this paper is Stefan Desch, and it was published in October. So the original study from Holger Thiele's group back in 2023, ECLS shock, took 420 patients with acute myocardial infarction, cardiogenic shock, so not all comers, and they looked at the added benefit or not of using peripheral VA ECMO, which was the largely or predominant used device, in outcomes in terms of 30-day all-cause mortality. And despite a fantastically well-conducted trial, there was a collective groan across the whole of the world because the trial was neutral. And there'd been a huge amount of hope that this would show that the device made a difference. It was a great trial. It was very well balanced. It was rapid enrollment, very good follow-up. It was adequately powered. There was a lot of discussion at the time about the percentage of patients that had been resuscitated. But that group, there we were at 1 year with no difference. They've now looked at the 30 days, no difference. They've now looked at 1 year, thinking maybe there would be a difference, and there is no benefit from the unselected use in VA ECMO in this patient population. And they looked at a number of subgroups. So they looked at stratifying according to the lactate, whether they had CPR, what type of acute MI they've got, whether they had diabetes, the age, the sex. No difference at all. And a very thoughtful commentary, I think, from Uwe Zeimer at the end of the paper, thinking about why this was a neutral trial and why there may be benefit perhaps in other devices. So in the last 12 months, we've had a trial published on another device, which is the microaxial flow pump, again in patients with acute myocardial infarction. And this is the danger shock study that we've been waiting for 10 years. This enrolled 355 patients, I think, were randomized. They screened over 1,200 patients. So this is a very, very selected patient population. They were quite sick, these patients. They had a low ejection fraction of 25%. They were randomized very rapidly to conventional treatment with or without the use of this microaxial flow pump. And they did show that there was a benefit from using this device. Now, there was a lot of discussion about this, and I think one of the best commentaries I've read on it is from Enzo Luzebrick, again in October 2024 European Heart Journal, where he really takes apart the trial and makes us begin to think about why the differences in the trials that we're seeing, what might the future look like, makes us think about the endpoints that we're looking at. Is it 30 days? Is it 180 days? What actually matters to the patients? Makes us think about the complexity of the critical care management of these patients, and really makes us think about the complication rates, because they were extraordinarily high in every device trial that we've got. And then in the same issue, if you're really looking towards unpicking what's happening with the sickest patient, there's a very nice article from Tom Lucia and Holger Thiele thinking about a paradigm shift in cardiogenic shock. So historically, in acute myocardial infarction, cardiogenic shock, there was a feeling that opening the artery was everything. Then there was a feeling that using devices would solve the problem. But the question is, should we think differently about cardiogenic shock, a little bit about the pro-inflammatory state and maybe the 1, 2, and 3 hit state that you have? So 1, from the initial insult, 2nd, the pro-inflammatory state of developing cardiogenic shock, and then adding in a device and an extracorporeal circuit on top of that. And this very, very nice and very thought-provoking discussion in the European Heart Journal Also minds me to, again, when I'm thinking of the future and whether we're going to go down immunomodulation for cardiogenic shock, also to look to the past, because 40 years ago in critical care, when we started looking at myocardial dysfunction and sepsis, there was a huge enthusiasm for blocking nitric oxide synthase, either selective or non-selective, and it did not benefit the patients that we brought together in those trials. So again, going back to individualization, what is the disease, the host response to the disease, and the response to the intervention, and can we select these patients better going forward? So those are my sort of three top-hitting papers from the European Heart Journal. Myocarditis, when to biopsy and what to do with the data. What about VA ECMO and cardiogenic shock? Was there a last hurrah from that? No, sadly not. And then a very, very intelligent debate about where are we going to go in future with cardiogenic shock.
Thank you, Susanna, for summarizing so brilliantly this important topic in cardiovascular medicine, an area where, as you have underlined, the progress has been so far limited, also because it's a complex disease, it's an end-stage disease, so we have a huge enemy in front of us to fight. But I'm sure that with our optimism and intelligence, we will make step forward in the future. Questions for this brilliant presentation from Susanna? If not, Susanna, along the line of your reasoning, we had this recent paper from Tom Leuscher on DPP3, which has been proposed as a biomarker and seems to work well, but might be also a therapeutic target. I remind our colleagues that DPP3 interferes with angiotensin II catabolism, and its blockade might be beneficial. Again, what do you see in your crystal ball?
So, Filippo, I think it's a very, very interesting potential therapeutic target, but I'm nervous. I think I'm nervous because I'm not sure we really understand cardiogenic shock well enough. And the key question for me is that personalization and individualization of an intervention, because we don't know whether having an elevated circulating DPP3 is beneficial or whether it's an appropriate adaptive response, or actually it then becomes a driver of the disease. And I think the thing with the paper in the ACS patients that showed that an elevated circulating DPP3 that stayed up conferred a 13 times increased mortality in these ACS patients. So they were more likely to get cardiogenic shock if it went up, but if it stayed up, they were much more likely to die. So being able to identify those patients and see whether intervening in those patients, so not all of the patients, might be beneficial, I think is interesting. And I'm hopeful, but I'm slightly nervous because again and again in critically ill patients, when we block things, they generally don't tend to do so well. And we're doing more, less is more when it comes to critical care. So we'll see. But of all of the potential interventions that are coming in terms of pro-inflammation, I think it's one of the most promising.
Thank you for your wise words. As I told you at the beginning, when I come to the four of you, not only a remarkable, incredible intelligence, but also your wisdom is something which is really inspiring. I have a very last practical question for you. We had some recent studies in the last 1-2 years about diuretic therapy. In addition to furosemide, there are three options: acetazolamide, thiazide, or gliflozin. Again, what in clinical practice, what do you suggest? Personalization again, or you have a favorite baby among the three?
So I think, Filippo, that when we're looking at the really sick patients, so I'd look to Cecilia for the less really critically ill patients, it's quite interesting. There are two schools of thought. There's one group of researchers and clinicians that are very, very aggressive with their heart failure therapy early on in the patient's course. And there are others who say, I think we should have a stepwise, cautious introduction when these patients are so sick for fear of destabilization. I think again that the one size fits all doesn't work when these patients are really sick. But I would also look to our trialists who have designed and implemented some fantastic therapies much earlier than we would have gone previously and historically. So we've been very cautious in our longer term heart failure introduction of these disease modifying agents. But to my younger colleagues, I remind them that what you're doing may be very acutely, particularly if the patient is at risk of developing cardiogenic shock or is just emerging from cardiogenic shock, is trying to implement a long-term disease-modifying agent when you've not got out of the acute critical illness. So you don't get necessarily the benefit that acutely. However, having said that, we do have groups across Europe who are very aggressive in introducing their heart failure therapy drugs and are introducing the full complement even when the patient may be still on acute mechanical circulatory support.
Thank you very much, Susanna. Let's close on these very interesting observations. And we are at the end of this very, very interesting hour with 4 distinguished speakers. We have reviewed the important papers published in the European Heart Journal in the last year in these 4 topics. I'm sure it's been stimulating for all of us. Before closing, a last remark from the four of you. I remind you that we have a large audience from the 5 continents now, including the Antarctic. Let's start with Lale. Lale, closing remark for our colleagues listening to us.
I wish everyone a very, very happy new year and look forward to all the exciting science that it is going to bring.
Thank you, Lale. Margarita.
I can only agree with Lale, and at this stage really thank everyone, and I wish you all a beautiful new year, and I wish us all to contribute more and work together, and this would be my goal for the next year. Thank you.
Thank you, Margarita. Cecilia, Mrs. President.
I would also like to thank everyone.
Yours is a presidential address now.
I think it's wonderful that people come together also on a day like this. For very many, it's a holidays day. I look forward enormously to 2025, and not in the least because we are working very much on advocacy in European Society of Cardiology, where Susanna is heading the Committee of Advocacy, and we are getting some breakthrough in the European Commission, which is fantastic. So that's my good outlook for next year.
Thank you. And Susanna, Mrs. Vice President, you're the champion of advocacy for the European Society of Cardiology. Your last remark.
So first of all, I wish everybody a very peaceful and prosperous new year. And then I'd say 2025 could be pretty exciting. You know, cardiovascular disease is right on the map now at a political level. And I think the opportunities to change things up for our patients is absolutely unprecedented. So exciting times ahead. Happy New Year, everybody.
Thank you, all of you. It's been an exciting year. Will be an even more exciting year. Please stay with us. Next dialogue will be the first of 2025, will be on Thursday, 30th, as usual, 17 Central European time. And really from our hearts, happy New Year. Bye-bye.